everyone. Let us continue from the previous session. My name is SPN Kumar. Today we are going to discuss about this biopharmaceutics. In the first unit, last session we have learnt about absorption. So today's session we will be learning about distribution. What do you mean by distribution? As we have seen from the previous session, the pharmacokinetic parameters, what body does to the drug, the pharmacokinetic parameters, what body does to the drug will involve the components such as absorption, distribution, metabolism and excretion. So previous session we learnt about what are the various aspects involved in the absorption and what are the different kinds of absorption: intracellular transport, paracellular transport and transcellular transport. So today's session, we are done with this absorption. So today's session will learn what do you mean by distribution, how your drugs are having differential distribution pattern, how one drug is showing more distribution, why one drug is showing less distribution. So we will see all those parameters in today's session. So let us move on to our session. So first of all, let us see what is meant by distribution. So distribution is the process where the absorbed chemical, say for example in our GIT tract, some drugs they may get absorbed from the stomach, some drugs they may get absorbed from the intestine. So no matter where the drug is getting absorbed, it has to reach into the systemic circulation. So from this area it will be the drug will be passing to the hepatic portal vein, from which it will be coming to the liver, and from the liver it is passing to inferior vena cava, where it accesses the heart. From the heart the drug is going to distributed all throughout the body. So that is how the distribution works. So let us see what is this distribution actually. So distribution is the movement of the absorbed chemical. So whatever the chemical, whether it may be paracetamol or amlodipine or atenolol, so whatever the chemical, so it has to move from the site of absorption. It may be stomach, site of absorption may be stomach, or site of absorption may be intestine. So it depends upon the pH of the drug. So we know the general rule, that is like dissolves in drug. Like, that means acidic drugs will be absorbed from the acidic medium, whereas the basic drugs will be absorbed from the basic medium. So that's the general thumb rule, so by which your drugs will be absorbed. So suppose we are taking salicylic acid, an agent which is used as a antifungal agent, acetyl salicylic acid, an agent which is used as an NSAID. Since they are acids, they are preferentially get absorbed from stomach. So if you are taking bisacodyl, so the drug is basic in nature and it is obviously gets absorbed from the intestinal medium. Why? Because the pH over here is slightly high, and which gives you that alkaline reaction. So that is about the absorption. So from the site of absorption it has to reach the affected site. So this entire process is called as distribution. The movement of molecule from the site of absorption to the area of action is called as distribution. So how this absorption is occurring? So let us see in other words. So it may be absorbed from skin. If you are applying a transdermal patch, so it will be absorbed from the skin. If you are taking any aerosol or inhalational anesthetics, so those will be getting absorbed from lung, or some drugs, majority of the drugs, they are taken by oral route, either sublingual films or normal conventional tablets or enteric tablets. So they are going to get absorbed from gastrointestinal tract. So from which sometimes we can also give an injection. So it can be an IV, intravenous, intraperitoneal or intramuscular injection, which directly accesses the bloodstream. So from which it enters into other areas of the body and finally it reaches the affected area. So it first should get distributed in the fluids, in the body's fluids. The body fluid can be classified as interstitial fluids and intracellular fluids. Your drug will get dissoluted into all this medium and gets distributed all throughout the body. So that's all about the contents of this slide. So let's move on to the next slide and see how the fluids are distributed all throughout the body. So interstitial fluid, it accounts for 15% of total volume in the total body weight. 40% is beared upon by intracellular fluids, and 8% of the body's fluids are constituted by blood plasma. You may ask me what happened to the remaining percent. So that's all the solid content. So all the water content in the body can be divided as this 15% of interstitial fluid, 40% of intracellular fluid and 8% of blood plasma. So if your drug is not in the affected area and not in the site of absorption, it should be in any of these fluids, either interstitial, intracellular or blood plasma. So comparatively, since the intracellular fluid is very high, obviously most drugs, due to the diffusion principle, since the solute molecules will move from high concentration to low concentration, they are more localized in the intracellular fluids. But in order to access that intracellular fluid, it has to permeate through the cell membrane. So let us learn all those parameters. What are the factors which are affecting one drug to distribute faster and the other drug to get distributed slower? So first thing is the rate of delivery. So the rate of delivery and potential amount of drug distributed into the tissues depends on. So sometimes your drug will be fastly distributed. So why that difference is coming? So the difference is coming due to the differences in cardiac output. We know that cardiac output is directly proportional to the drug distribution. So higher the cardiac output, higher will be the drug distribution. Suppose there is a patient who is suffering from tachycardia. So obviously his drug distribution is faster when compared to other normal adult individuals. Suppose there is a person who is suffering with congestive heart failure, his cardiac output is going to be lower and obviously drug distribution is also going to be lower. So reasonable blood flow. So even though our body is having more or less the uniform blood supply, some organs, they are called as highly perfused organs, so well perfused organs, which means for these organs the amount of blood supply is very high. So let me give you the examples. Liver, kidney and brain are kind of having more amount of circulation when compared to the other organs. So let us take these things like muscle or viscera or skin or fat. These are having less amount of perfusion. Perfusion is the amount of blood that reaches that organ in a given interval of time. So these are less perfused organs and these are well perfused organs. So obviously if you are giving a drug, it reaches more equilibrium at these sites and reaches less equilibrium at these sites. So if a patient is suffering from cancer, who is having some cancer of skin, some carcinoma or sarcoma of skin, so obviously the drug is going to get distributed lesser in the skin. So that means you need to give more and more amount of dose in order to reach or access the skin. So these are the points to be borne in mind while we are designing a dosage form. So next is, let us see some more other parameters which are affecting this distribution. So it gives you, distribution gives you a function of transport of drugs into the site of action, such that higher the fast of distribution, higher will be the amount of its excretion. So it is not at all uniform. Drug distribution is not uniform for all drugs. It depends upon its several features like its pH, ionization potential, its hydrophilicity or lipophilicity. So main differences are difference in perfusion rate, so that is the amount of blood supply to that particular organ, and the amount of drug that is penetrating to the capillary endothelium. Sometimes a drug is so small, its molecular weight or size is so small that it can easily permeate through the capillary endothelium, whereas some they are not able to pass through it due to the high molecular weight. So molecular weight and its size or shape also matters with respect to the distribution. Next is diffusion across the cell membrane. See, some drugs, cell membranes are lipoidal in nature. They are consisting of phospholipids. These are lipoidal in nature. Obviously we know like dissolves in like. So there is a drug which is lipophilic. So obviously this drug is going to permeate easily across the cell membrane, because the cell membrane is also made up of phospholipids which easily have affinity towards this lipophilic drug. But this is quite opposite in case of a hydrophilic drug. So point to be borne in mind. Next. So let us see some parameter which can be mathematically notated such that we can use it while we are designing or implementing a dosage regimen or dosage form. So distribution is, as we are seeing from the past two slides, it is the amount of drug which is reaching the various organs, not only the affected site. The drug gets into equilibrium to all the organs. So the apparent volume, so in order to make it into a measure, so we are taking into a fact called as volume of distribution, which is also called as apparent volume of distribution. So for a comparison, so we can use this apparent volume of distribution, which is a fraction of this diffusion constant, plasma concentration and rate order kinetic constant. So suppose some drugs may follow first order kinetics, some drugs may follow a zero order kinetics. If you take a ratio between this diffusion and the plasma concentration, the value we are getting is apparent volume of distribution. So the reason why we are calling this as apparent volume of distribution is it is just a relative measure. It's not a general or authentic measure. It is just a relative measure to see which drug is comparatively getting more distributed and which drug is not distributed properly, right? So let us move on to the next slide and see some of the parameters. Say for example, the apparent volume of distribution may have a value of 5 ml to 400 liters. So it is the range of volume of distribution. So a drug which is having a VD of 400 liters means it is having more distribution ability when compared to the other drugs. So let us see some generalization. So the bold sentences which is over there, those are the generalizations from this apparent volume of distribution. So as I have said previously, this is a relative measure, just only artificial concept to see the relative performance of the drugs. Next, it is helpful to predict or forecast the amount of drug in the blood or in the tissue. So a quite obvious fact that, say for example, there is a drug which is hydrophilic in nature, which means a water soluble drug. Since our blood is also having 90% water, obviously the drugs which are hydrophilic are going to reside in the blood, and the drugs which are lipophilic in nature, so it is obviously going to reside in the adipose tissue which is having fat. Fat is nothing but lipids, and you know, like dissolves in like. So drugs which are charged, say for example, there is a drug like salicylic acid which is capable of ionization or charged ions. So then they will bind to the serum proteins like albumin, globulin, histidine, etc. So whereas the uncharged drug, they will not bind to the plasma protein. So we will learn about this protein binding in the next session. So what is meant by protein binding and how it is going to affect the drug distribution or drug absorption from a dosage regimen. So next is the mathematically this VD will give me how much amount of drug is present in the blood, such that I can know how much amount of drug is eliminated and I can give a second dose or the third dose as the case may be. Next. So volume of distribution, so why it is especially helpful is for drug monitoring. So let us take some drugs which are having very narrow therapeutic index. Let me give you examples. Drugs such as digoxin or lithium carbonate, these are having very less therapeutic index, very narrow therapeutic index, which means so this drug can be toxic if the dose is not properly controlled. So how can you see the safety of the patient? How can you ascertain the safety of the patient? You can ascertain the safety of patient by measuring this apparent volume of distribution. Before giving the next dose, see the apparent volume of distribution. If it is still high, so restrict the second dose. If it is low, give the second dose such that the patient receives the therapeutic benefit but not the adverse effects. So psychotropic drugs, so the drugs, say for example the barbiturates, benzodiazepines or tricarboxylic antidepressants, all these psychoactive agents, so they have the high lipophilic in nature, so they are very lipophilic in nature, hence they can easily cross the blood-brain barrier and they will localize in the central nervous system. Their volume of distribution is above the central nervous system by bypassing this blood-brain barrier which is lipophilic in nature. So that's all about, so this is a comparative table how the drugs are having different values of volume of distribution. So let me take two examples such that you can have a better idea. Say for example salicylates. See, salicylates are having very less volume of distribution. Why? Because salicylates, they are acidic in nature, so due to that ionization potential they are going to divide into plus and minus cations and anions, hence they will bind to the proteins. Since they are binding to the proteins, they will have less VD values, whereas let us take a very high value here. So this phencyclidine, which is localized in the central nervous system, it is not ionized, so it will be present in an unionized state, hence it will be present more in the blood rather than in the binded state or in the tissue binding state, so hence its VD will be higher. So a comparative profile of various drugs. So next, So let us make a generalization summary of what we learned until now. So it is an abstract concept. Abstract in the sense it is just a relative concept to compare the performances of the drug, and it gives information of how the drug is distributed in the body, whether it is well distributed or bound to the proteins. And finally it is used for calculation of loading dose, such that I can adjust my dosage regimen to the needs of a patient. So that is the summary of what we learned, and for this VD, volume of distribution. So one other terminology, one other parameter to assess the drug function, drug distribution, is clearance. So what do you mean by clearance? Clearance is the amount of drug which is getting excreted from the body in a given unit of time. So let us see the definition which is given. So it's the ability of organs of elimination. So there are principally kidney and liver. These are the two main eliminating organs. So the amount of drug that is being eliminated from the body per a given unit of time, it is called as clearance. So amount, that is volume, per a given interval of time, hence the units are liter per hour or liter per hour per kg. So this clearance and volume of distribution are having a indirect proportionality constant. So usually when the volume of distributions, these two are independent variables. So by taking this VD and clearance into consideration, we can adjust the dose or monitor the effects on the patient, and we can prevent the adverse effects. So clearance, so here is a good definition. So volume of blood in a defined region of the body that is cleared of drug in a unit time. So once the drug is distributed, it has to be cleared from the drug with the help of eliminating organs. So that is called as clearance. How much amount of drug is getting cleared from the blood every unit of time, it is called as clearance. So clearance varies with the body weight. So higher the body weight, higher will be the pressure on the kidney to relieve or to clear this drug. So hence it varies with the body weight. It also varies with the degree of protein binding. So higher the protein binding, lesser will be the clearance. Higher the protein binding, lesser will be the clearance. It's an inversely proportional relationship. And what are the factors which affect this distribution or permeability of the drug? So first thing is the physico-chemical properties of the drug, like its pH, ionization, what is it, an acid or a base, all those parameters, and how much amount of drug is bound to the plasma, is it in a free state or in a bound state. Next is how much amount of blood is flowing to the tissue, highly perfused organs or lowly perfused organs. Previously we gave an example, brain, liver, kidney, etc. are highly perfused organs. Skin, muscle, bone, viscera, etc. they are low perfusion organs. So special compartments and barriers and disease states. Sometimes when a patient is suffering with tachycardia, his cardiac output is going to be higher and the volume of distribution is also going to be higher. So let us come see, we learnt that these are the parameters. The first one is physico-chemical parameters. So let us see only this one, physico-chemical parameters in detail. So what are the physico-chemical parameters? So this is our main heading now. Now let us see the subtopics under the physico-chemical properties. So drugs whose molecular weight is less than 500 to 600 Daltons, they easily cross, obvious fact. So whenever the particle size is lesser, it can easily permeate through the cell membrane and can show the action. And passage of drugs from the extracellular fluid into the cells depends upon the molecular size. Lesser the size, more will be the distribution. Degree of ionization, usually, so lesser the size, more will be the distribution. And ionization, only unionized drugs will be distributed better when compared to the ionized drug. And lipophilicity, whether your drug is lipophilic, since cell membrane are made up of phospholipids, only lipophilic drugs are better distributed in the body, so will get better distributed in the body. So next, water soluble drugs and which are having less than 50 Daltons of size, they are passing or distributing through the body by aqueous fluid channels, whereas those drugs which are having larger size, they need carrier transport system to get distributed all throughout the body. And according to pH partition hypothesis, so the basic drugs present in the blood readily enter into the acidic tissue. So some amount of drug will be ionized and it will be entering into the acidic tissue. So that is according to the pH partition hypothesis. And so there is quite an example over here. So weak organic bases administered parenterally gets diffused in the blood and the fluids when the pH is 5.5 to 6.5. The reason why this is happening is, so when there is a difference in pH, the drug is undergoing ionization. So this ionization is going to affect its distribution. So these are all the generalizations how one drug is behaving differently when compared to the other drug. So drugs are transported into the circulating blood in two forms. Either they will be in free form, unbound state, or in bound form. So free form of drugs is usually dissolved in plasma. So whenever it is free, it can be freely soluble in plasma, but whenever it is bound to the proteins like albumin, globulin and histidine. So we'll learn about that albumin, globulin, histidine shortly. So this is called as protein binding. As I have said previously, some drugs can bind to the proteins, which is called as protein binding. So since it is bound to the proteins, the distribution of the drug will be reduced and it becomes pharmacologically inactive. It's no longer active, it can't show its response on the body. So it is non-diffusible and it is not available for metabolism or excretion, so which can cause cumulative toxicity. It will stay in the body for a longer period of time due to the protein binding and can cause cumulative toxicity. So as they cannot pass through the capillaries and cell membranes because of their larger size. So protein bounded drugs, they have a high molecular size, they get restricted in the body, accumulated in the body and can cause toxicity. So plasma protein binding can be reversible sometimes, or it can be irreversible by permanent bonds, formation of bonds like covalent bonds. So some drugs may bound to a very little extent, example is theophylline. Some may get protein binding to a very high extent, example is warfarin. Warfarin and phenylbutazone is a very good example of protein binding, how it can cause a drug interaction. Next, in circulating blood there is a constant ratio between the bound and free fraction. So this sentence seems a bit strange, so let us explain this sentence with an illustration. So let us see this illustration such that you can understand it better. So in the body, so there is free amount of drug and there is drug which is bound to the protein. So only the drug which is in free state can cross the membrane and can show the effect. So you can learn from this illustration that only free drug is effective, it is effective, whereas bound drug is not effective, it is ineffective. So hence protein binding can reduce the distribution as well as reduce the therapeutic response of the drug candidates. Next, so a large variety of drugs from weak acids to weak bases, any kind of drugs, they are subjected to protein binding. So we have the plasma proteins such as albumin. So usually acidic drugs A will bind with A, that is albumin, they will bind with albumin, whereas basic drugs they will bind with glycoproteins, alpha acid glycoproteins or other plasma proteins like globulins. Acidic drugs will bind with albumin, that's our generalization, and another conclusion is basic drugs will bind with glycoproteins or globulins. So whatever I said in the previous sentence, so we gave examples here, examples of acidic drugs that binds to albumins, examples of basic drugs that binds to globulins. So there are other generalizations. Usually majority of the drugs binding to plasma albumin so is quantitatively more important because albumin is the most dominant plasma protein in the body. So higher the amount of acidic drug, higher will be the amount of protein binding to albumin. So important. Next is the binding of drugs to albumin may show low capacity or high capacity depending upon the nature of the compound, whether it is an acidic drug or a basic drug. So here are some examples. Albumin can bind to maximum amount of compounds. Some other drugs, for example phenytoin, etc., they can bind to other plasma components like RBC or other cells of blood. So here are some examples which bind to the albumin and can cause therapeutic interference, which are the drugs which can bind with glycoproteins, and these are the drugs which can bind with the lipoproteins, and how they are causing the interference with the pharmacological response. So binding to tissue proteins, not only plasma proteins, even our tissues have proteins. Drugs can bind to this plasma proteins or phospholipids or nuclear proteins and can cause effect to drug distribution or therapeutic response. So why this protein binding, tissue protein binding is very important. It's very important. Why? Because it can cause local toxicity. It get localized in that particular area and can cause more predominant effects. Say for example, aminoglycosides like streptomycin, kanamycin, gentamicin can cause more amount of renal compromise, nephrotoxicity or vestibular toxicity. So here are some more examples: paracetamol causing hepatotoxicity, tetracycline causing discoloration to teeth, chlorpromazine causing retinopathy, vision disorders. All these are examples of local tissue toxicity. How these can cause drug interactions or can affect the half-life is tabulated in the given illustration, such that we can have a better idea at one glance. So drug displacement interaction. So I'll give you one case scenario. With that we can wind up this session. Say for example, there is phenylbutazone and there is also warfarin. Suppose there is a patient who is prescribed with this warfarin. Warfarin is having the property of protein binding. It can bind with the proteins like albumin, globulin, histidine. So the patient first took the warfarin, it bound to the proteins. Let us suppose in the second dose he have taken phenylbutazone, but the problem is phenylbutazone has more amount of protein binding when compared to warfarin. What happens in the body is this phenylbutazone will displace the warfarin which is bounded to the plasma cells. So what we think is warfarin is not showing the effect. What happens after administration of phenylbutazone is it shows more effect on the body. Warfarin will be displaced from the plasma proteins and it can cause severe hemorrhage or internal bleeding, can cause tissue destruction or can cause damage to the homeostasis. So these are all some phenylbutazone and warfarin, whatever we learned until now is generalized in this slide. So whatever the things we learnt about warfarin and phenylbutazone, it is given as a number. So 99% when it is present as a free drug, it can displace 1% of the phenylbutazone, causing serious drug interactions. Even fat, the subcutaneous fat in the adipose tissue can also act as a carrier where your lipophilic drugs will get accumulated. So it will change depending upon whether the patient is obese or lean. Obese patients have more fat content and it can result in accumulation of lipophilic drugs. So the blood flow and the organ size, higher the blood flow, higher will be the distribution, higher the organ size, higher will be the amount of distribution. So this is all the facts whatever we learnt now. The conclusion things are written on this slide. And finally the blood brain barrier. So for your drug to cross this blood brain barrier, it should be lipophilic. Not only blood brain barrier, there are also other barriers like blood testicular barrier or blood placental barrier. So our drugs need to cross all these barriers in order to show their effect. So this is a discussion about placental barrier and other barriers. Your drugs should need to bypass these barriers or overcome these barriers in order to show the effects. And finally disease state. Some diseases like meningitis, encephalitis, etc. can alter the membrane kinetics and can affect the drug distribution. And hypoalbuminemia, there are patients who have less amount of albumin. So we on a general note think that the patient has albumin, normal albumin, and will administer double dose of the drug. But since the patient is having hypoalbuminemia, the drug may get displaced or may not bound to the albumin and can show toxic effect on the body. So once it is released from the tissues, it can get redistributed in the body and can cause more serious effects. One example is thiopentol. It gets redistributed and can cause more and more amount of general anesthetic property. So that's it about this drug distribution. So in the coming session we will see other parameters like metabolism and excretion which are affecting the biopharmacokinetic parameters. Thank you everyone.